Dopamine is not a substrate for that carrier. L-DOPA is. The carrier has a strange name. It's not a selective carrier. It's called the large neutral amino acid transporter. Sometimes they call it the large neutral amino acid pump. Same thing. But the key thing I need you to understand is that we have active transport of L-DOPA from the intestine into the blood and from the blood into the brain. So you need that carrier. Dopamine is not a substrate for that carrier, so we can't just use dopamine. Okay? Now, once the L-DOPA does get across the blood-brain barrier, remember active transport, the L-DOPA is uptaken by the dopamine neurons. Okay? Uptaken by the dopamine neurons, and then I am right. Inside the dopamine neurons, you have the decarboxylase. The decarboxylase converts it to dopamine, and then the dopamine is stored in the vesicles. You with me? The L-DOPA is transported across the blood-brain barrier into the brain. That L-DOPA is uptaken by the dopamine neurons, and once in those neurons, it meets up with dopa decarboxylase, aromatic amino acid decarboxylase, where it's converted to dopamine. And then dopamine is stored. Okay. L-DOPA is considered the gold standard treatment of Parkinson's disease. But it's not without its problems. We'll talk about that a little later on. But it is considered the gold standard. Okay? It's the most effective agents against all those cardinal symptoms we talked about. All the cardinal symptoms. It's the most effective agent. Okay. In addition to decarboxylation, L-DOPA can be metabolized in the liver and brain by COMT to 3-O-methyl-DOPA, which is inactive. So L-DOPA gets methylated, is inactive. You do have in the liver, okay, you have COMT. So it can be inactivated in the liver. You also have monoamine oxidase in the liver. We'll talk about that in a few minutes. Okay, behavioral effects. Don't really care about it. It appears to have no effect in the normal individual. In patients, there may initially be changes in mood, apathy replaced by a sense of well-being, the interest in self, surrounding, and family. Well, of course, when you can't move, all of a sudden you can move. Okay? Yeah, you're going to feel a little better, a little more better about yourself. Okay? Cardiovascular. Don't forget that L-DOPA can be converted to both norepinephrine and eventually epinephrine too. Remember, L-DOPA is a precursor to both of those. So the norepinephrine and the epinephrine produced can lead to increased alpha and beta activity, alpha receptors and beta receptors. Normally not much of a problem, by the way, unless you use an MAOA inhibitor, which we'll talk about later on. The only time it really becomes a problem if you use an MAOA inhibitor along with the L-DOPA. Then you have a problem. Okay. Little 2 there. I would cross that out because it's not really true. Okay? We do know much more about it than we used to. So the 2 I's there, number 2, I wouldn't even read that thing. Don't let it throw you off. Okay. The endocrine effect. Okay? Don't forget that when L-DOPA is converted to dopamine, what's the effect of dopamine on the anterior pituitary? Prevents the release. So you get hypoprolactinemia. This is not related to the Parkinson's disease. This is just something that a side effect. Okay. L-DOPA is the most effective therapy for Parkinson's, with 50% of patients showing dramatic improvement in the cardinal symptoms of the syndrome. L-DOPA is rapidly absorbed by the gut. Now, here's the problem with L-DOPA. Okay? If it gets decarboxylated in the periphery, okay, and if it doesn't all get absorbed, not much of it's going to reach the brain. In fact, if you don't use carbidopa, we'll talk about that in a few minutes, only 1% of the dose actually reaches the brain because of decarboxylation or methylation in the periphery. Decarboxylation or methylation in the periphery. Okay? If we use carbidopa along with the L-DOPA, we'll explain what that does in a few minutes, we get it up to 10%. So most of your dose of L-DOPA is lost. Okay? And what I would like to show you is then is why it's lost. L-DOPA in the stomach, okay, there's aromatic acid decarboxylase. That's going to take L-DOPA and convert it to dopamine. So as soon as you convert it to dopamine, it's inactive. Because remember, dopamine cannot be transported from the gut into the bloodstream. So you have aromatic acid decarboxylase there. You have it in the gut, in the intestine. Same place, same thing. It can be metabolized to dopamine, and you lose it. You go to the liver. You have aromatic acid decarboxylase, which can decarboxylate it. And you also have COMT, which can methylate it. Both of those actions, okay, both of those actions, okay, will inactivate the drug. Then, okay, once you cross the blood-brain barrier, then you can convert it to dopamine. That's where we want the decarboxylation to occur, within the neurons, okay? Within the neurons. That's when we do want a mere aromatic amino, I hate that word, dopa decarboxylase, same thing. AAADC is the same thing as dopa decarboxylase. Now, what we usually do is we combine L-DOPA with something called carbidopa. Carbidopa is a peripheral, doesn't cross the blood-brain barrier, inhibitor of dopa decarboxylase. It's a peripheral inhibitor of dopa decarboxylase. So where you see this here, where you see this aromatic acid decarboxylase, you're going to inhibit it here in the stomach, you're going to inhibit it here in the gut, and you're going to inhibit it here in the liver. So that means you're going to have more of the L-DOPA available to go to the brain. Where you don't inhibit the decarboxylation in the brain. Why? Because it crossed the blood-brain barrier. Okay? So, what's another enzyme if we inhibit it? What's another enzyme if we inhibit it? Will increase. COMT. COMT. By the way, I was wrong. Monoamine oxidase does not destroy L-DOPA. It's not a substrate. But there is monoamine oxidase in the liver. Okay? But COMT and dopa decarboxylase. So what we do is we combine L-DOPA with carbidopa, and that combination is called Cinnamate. Okay? That combination is called Cinnamate. Okay? If you use this, remember, if you don't use Cinnamate, okay, if you don't use Cinnamate, only 1% of your dose reaches the brain. Even with Cinnamate, only 10% reaches the brain. Now, so by using Cinemet, we increase the amount that reaches the brain. But that's not its greatest attribute. Let me see if you can figure this out without reading it. If we form L-dopa in the periphery, where are we going to have a problem also? Something that's going to be on tomorrow's test.
Repeat the question.
If you convert dopamine in the periphery, you're going to have a lot of dopamine in your bloodstream. Where might we have a problem? In the CTZ, the nausea and vomiting center. The dopamine converted in the periphery will cause nausea and vomiting. Remember, the CTZ is not behind the blood-brain barrier. If you use L-dopa alone, 80% of people will throw up. On the L-dopa alone, if you use the combination, it goes down to 20%. That's going to be stated elsewhere in here, but I just wanted to preview it. That's probably its greatest attribute. You do get more to the brain, but you decrease the nausea and vomiting. All right, let's go back. Yes?
Is there a coenzyme inhibitor?
Yes, there is. We'll talk about that later on. Okay? There is there's two of them, actually. We're going to talk about all the ways, you see it. We're starting right now with L-dopa. Okay. Some drugs may be contraindicated during L-dopa therapy. Okay? Antipsychotic agents. Why? Why are they contraindicated? Well, they block D2 receptors. There are some that aren't. We'll talk about that. There are certain antipsychotics that don't block the D2 receptors very powerfully. One of them is a Seroquel. The other one is Clozaril, which you didn't know about yet, that you can actually use with them. But, okay, and Reserpine, which nobody uses anymore in the thing. Reserpine is a dopamine depleter. So don't worry about those. But antipsychotics, now, non-selective MAOA monoamine oxidase inhibitors, we have a problem here, especially monoamine oxidase A inhibitors. Here's what happens. L-dopa is also the precursor to what? Norepinephrine. Okay? Now, you also have MAOA in the liver. If you inhibit MAOA, okay, what's going to happen to, and you also have MAOA, in the norepinephrine neurons themselves. What's going to happen? You're going to L-dopa will increase the synthesis of norepinephrine, okay? At the same time, you're going to inhibit the metabolism of norepinephrine by inhibiting MAOA. What's going to be the problem with too much norepinephrine in the periphery? Constriction, okay, and you get what we call hypertensive crises. Now, if you combine the two, you unpredictably, okay, can get this, what they call hypertensive crisis. So we cannot use them with non-selective MAO inhibitors. However, we can use them with MAOB inhibitors. L-dopa with MAOB inhibitors. Why? MAOB does not metabolize what? Norepinephrine. It's selective for dopamine. Okay? So we don't have the problem with selective MAOB inhibitors. Okay. Now, if you are just taking L-dopa alone, you should not give them vitamin B6 supplements. Why? It's a cofactor for dopa decarboxylase. And what's going to happen is, if you give vitamin B6, you're going to enhance that decarboxylation in the periphery, which means you'll form dopamine, and dopamine can't cross the blood-brain. So you're going to lose it. Now, if you're blocking, the decarboxylase with carbidopa, you don't have to worry about it. So it's only a problem if you're using the L-dopa alone. Toxicity and side effects, blah, blah, blah. blah, that first statement on number 4. Don't worry about it. By the way, what they usually do is titrate the dose up to the least effective.